Hello and welcome to everyone to the Supporting Student Success in Schools, exploring the impact of the Behavioral Health Student Assistance Program hosted by the Bree Collaborative. My name is Emily Noodleman and I'm the Director of Implementation and Outreach at the Bree. We're excited to have each of you join us today as part of our Behavioral Health for Youth mini-series. During the series, we are highlighting initiatives across the state aimed at enhancing youth behavioral health. We recognize that behavioral health encompasses both mental health and substance use disorders, which affect the emotional, psychological, and social well-being of individuals and communities. In our recent Bree report on behavioral health early intervention for youth, we highlighted some key resources and examples of work going on in the state, such as this one, the Behavioral Health Student Assistance Program, and we're excited to highlight it further today with all of you. This initiative, created by the state's 9 educational service districts, also known as ESDs, was in response to the pandemic, aims to expand the student mental health support by integrating behavioral health services into our school systems for youth. During the presentation today, we will give an intro to the Bree Collaborative in our new report. Then we will hear from our speakers on the Behavioral Health Student Assistant Program, followed by a Q&A with our speakers. At the bottom of your screen, you should see a box that says Q&A. Please place any of the questions you may have there so we can review and ask them on your behalf to our speakers. The webinar is being recorded, and we will plan to send out this recording and a PDF copy of our slide deck to all of those that signed up to attend. We will also post the recording on our website. The learning objectives for our mini-series are shown on this slide. We hope through the presentation today that you can gain a deeper understanding of the Bree and the report on early intervention for youth. We are identifying a tool, resource, or program in the state that supports youth behavioral health, and describe a key resource or strategy for early intervention in youth behavioral health. As a brief introduction to the Bree Collaborative, it was developed in 2011 by our Washington State legislation, so that public and private healthcare professionals would have the opportunity to identify specific ways to improve healthcare quality, outcomes, and affordability in our state. Our members identify healthcare services with high variation in the way that care is delivered, frequently used but do not lead to better care or patient health, or have patient safety issues or inequities. For most topics, we form a work group of subject matter experts, which some of them are kindly here today, and leaders to develop this report. Our report provides guidelines for multiple audiences, such as clinicians, delivery systems, plans, purchasers, and others like schools, to really encourage collective and collaborative action to promote optimal health for Washingtonians. Our reports are focused in Washington State. However, we recommend anybody can look at them if you're from out of state too. This past year, we facilitated a work group on behavioral health early intervention for youth, referring to and focusing on how do we support youth before they experience a mental health or behavioral health crisis. Our members discussed how in 2021, 35% of 8th graders in the state reported depressive symptoms for 2 weeks straight within that year. And we also saw that 1 in every 5 high school students reported seriously considering attempting suicide during that year. And this was both on a national level, but also at a state level. Instead of waiting for that crisis to arise and overwhelming the already limited psychiatric crisis support, our members recognize Washington State youth require support and treatment in addressing a short-term behavioral health condition. How can we help them again before this crisis really exists? But we also recognize this help can be difficult to find, receive, and afford. Youth need to receive high-quality, timely interventions to promote their mental health and well-being, learn skills to build resiliency, to manage mental health symptoms or behavioral health as they arise, and health promotion interventions involving the child, youth, families, and those that are in their community that form their support system. This is why the Bree chose this topic, and this report was published in January 2024. The report aims to promote activities to identify and to address behavioral health concerns as early as possible before they become severe. Intervening early can prevent or reduce the severity of symptoms, improve functioning and development. We've seen enhancement in protective factors and resilience, and lower the risk of negative consequences such as academic problems, substance use, or suicide. Our report does focus on anxiety, depression, trauma, disruptive behavior, and substance use disorder, just due to their higher prevalence and availability of evidence-based treatments, but we do recognize there are other symptoms and diagnoses you could experience. We are so excited to host this mini-series and really excited to highlight this program today. I am so excited to introduce our speakers to you. We have Erin Wick, who is the Executive Director of Integrated Student Support within ESD 113. We have Dr. Bruns, who is a co-director for faculty development at the University of Washington and Associate Director of the SMART Center. And Adriana Mercado, who's the Regional Behavioral Health Coordinator for ESD 123. So I will welcome them forward to kind of further introductions and talk more about their program.
So I'm Erin Wick. I'm the Executive Director of Integrated Supports at ESD 113, but I'm also the Association of Educational Service Districts Behavioral Health Student Assistance Program Lead. And with me today, I have Dr. Eric Bruns. I'll let him introduce himself.
Hey everyone, Eric Bruns. I'm here in Seattle in our off-campus offices of the University of Washington School Mental Health Assessment Research and Training Center, or SMART Center. And I'm a professor of psychiatry in the Department of Psychiatry here in the School of Medicine. And I'll hand it over to Adriana.
Hi, I'm Adriana Mercado, and I am the Behavioral Health Coordinator. I am stationed in Pasco, Washington, and supervise some of the behavioral health SAPs in our region. I'm happy to be here.
And so what is an AESD network? So there are 9 educational service districts in the state of Washington, and the 9 of us comprise of that AESD network. On this slide, you'll see that we cover the full state. So all 295 school districts receive some type of supports through the ESD network. The majority of these services are teaching, learning, school district operations, and then of course we have our direct student support services such as the behavioral health program that you'll hear about today, behavioral health navigation support, our school safety centers. So lots of resources for schools. And you can contact any of the staff that are listed on this slide if you have additional information that you want for your specific ESD region. Next slide. There is just more information about the region in which we serve, and the contacts there are the superintendents for those districts. Next slide. So we are really excited to talk to you about our behavioral health student assistance program. We launched this program in 2021 as part of the COVID response funding that we were receiving to address the issues that we were seeing across the school districts with remote learning and some of the challenges that we were seeing there. So we did launch this program to 51 sites across the state using those ESSER funds. In 2023, we renamed the program because we moved away from the COVID relief dollars and moved into legislative funding. And we were able to serve about 60 sites that year. In 2024, this last school year, we have had to reduce down to 18 sites due to some funding reductions at the state level. And so our hope is to continue to at least have our 18 sites and potentially increase that over time. Next slide. So what is a student assistance program? When we launched this behavioral health student assistance program, we took the existing model of student assistance, which has been around for over 30 years. It's a comprehensive framework that allows us to deploy services in the K-12 system to a range of behaviors, to reduce risks in a range of behaviors. In Washington State, we've been using the student assistance program for our substance abuse programs for over 25 years. And so when went with OSPI to develop the behavioral health student assistance program, we really just built that out, taking what we had learned with our substance abuse program and built out the mental health and wellness side of the model. And so both of these items, you'll be able to link on the slides, and they'll get you the resources. So the Student Assistance Administrator's Guide is on the SAMHSA website. It's part of their evidence-based practice work. And then also the Office of National Drug Control Policy, the Student Assistance Program is also highlighted there as an evidence-based strategy for mitigating substance use. So pretty exciting work at the national level there. Next slide. So when we decided to build this project, we wanted to make sure that we had a solid foundation and a solid infrastructure. Oftentimes when we have programming, we're not really thoughtful about really making sure that we have solid foundation and infrastructure, solid staffing and evaluation built in. So we were really, really thoughtful about making sure that we had statewide coordination and evaluation as a core component of this work, so that we knew that what we were doing was either effective or not and could change if it wasn't showing the outcomes that we had. We also knew it would be super important to have a coordinator at each ESD, and that's Adriana. You'll hear from her in a minute. So she is a coordinator at ESD 123. We have 9 coordinators in the state that are really working to make sure that this program is being deployed to fidelity in those regions. And then, of course, the student assistance professional that are the professionals that are responsible for all of the direct services out in the districts. Those direct services are really important. And then we also wanted to capture the importance of connecting to family and community. So making sure that we're doing community and family events and working with school districts and community partners to really change some of those community norms and reduce stigma as a system. And then also staff engagement and awareness. So that is built into this component. Those SAP coordinators support their student assistance professionals and the school district administration in that. And then really that highlighting that school-wide awareness. So we were very intentional with the setting up of the infrastructure of this program, which has proven to be super valuable as we've deployed the program for going into 4 years. Next slide. And I'm going to turn it over to Adriana to talk about all of the fabulous things that this program does.
Hello. So the first part we're going to go over is some of our tier 1 services that we provide. Again, Erin talked about the importance of family engagement, community engagement, and these are really important with staff engagement as well, because at the end of the day, they are ESD staff who are coming into buildings. So it's important that the staff in the building is also trusting the individual that is launching those services. And so we've come up with various ways for them to get their face in front of individuals, build those relationships at a staff level, family level, so on and so forth. Next slide. So our staff awareness presentations. So we do ask that all of our SAPs at least attend quarterly staff presentations. And what we expect them to do in these is, 1, get your face out there, allow the staff to know what is it that you're doing here in our building. How is the referral process? How can we recognize signs and symptoms in our students that we're serving to see if they're an appropriate referral for them? It's really to just have that sense of belongingness too, but also we know the beginning of a school year can be rough. So coming to the first staff meeting at the beginning, that service may be forgotten about. So coming again during the holidays, coming again during, spring, however their quarterly meetings are dispersed, just to ensure that the SAP is out there, they're showing their face, they're showing that they're a resource for everyone. Next slide. Our classroom presentations. So we do ask that every SAP performs 1 substance use classroom presentation and 1 mental health classroom presentation, whether that be on stress and anxiety, vaping, and it is better practice to do that across a grade band. So whether that be all 7th graders, 8th graders, 6th graders, whatever building they're in, middle school or high school, we ask them to also pick a course that every student gets in that grade. So whether that be a health class, a history class, PE, whatever it may be. But this also allows for the SAPs to build that relationship with students they may not have contact with. So oftentimes there may be resources in the building that not all kids are aware of. But when you are going into a classroom and showing your face and what you do, there's some self-referrals that could come out of that as well. And so a student could put, hey, a face to a name, this is what they do. Maybe I'm going to go and talk to them afterwards to see if there's any other resources they can provide. Next slide. Our parent and our community training. So our SAPs do a really good job at being at every family event, handing out resources like, hey, this is who I am, this is the support that I provide, which is fantastic. But we also ask that they educate them with substance use prevention or mental health symptoms. And they do that by partnering sometimes with other agencies or other ESD employees who may be trained in suicide prevention, youth mental health first aid training, and then collaborating with the building and other agencies to see like, okay, when can we launch this? What time of day is best for your population at your building? Because it's different for everybody. And really, it's a coordinated effort to ensure that we're getting as many parents in or community members in to really reduce stigma on mental health concerns and having everybody know like, hey, you have resources here or there, and getting more youth some help. And then also putting a face to the name, parents knowing, okay, this is this person that is serving my son or daughter's school. Can I have your card? Can I maybe call you later to see like if this is an appropriate thing for my youth? Next slide. Youth leadership in prevention clubs. So we try to partner with the youth for our launching of campaign events because you think youth are cool. They don't think that we are as adults cool. So having them be involved and how can we create activities and educate your peers on how to get help, how to decrease substance use, how to just have a whole system in place with your peers, and also having some ownership of that. If you have a club in there and they feel like they're doing something important, it usually is launched in the best way. And then it also educates those youth that are involved in some of those campaign work or some of that prevention work to also recognize, hey, I have a friend that's not doing well, but I know I have this resource. So you're educating a group of kids on not only how do we reduce the stigma, but also how do I get them help if I need to. Next slide. So our universal prevention campaign. So our SAPs are, I say the word required, but it is expected that they at least do the core 4. And that's our suicide prevention month, our bullying prevention and unity weekday, our substance use prevention campaigns, and our mental wellness. We do have additional ones, and it really is dependent on the building. So we want the SAP to focus on those interventions, the one-to-ones, the groups. So if they have a caseload and the acuity is too high, they may not have all the time in the world to do more than these 4, but these are the core 4 that we expect each to do. Okay, next slide, please. And these are some examples of our mental health stigma reduction campaigns. We use Seize the Awkward or Are You Okay? And again, it's dependent on the SAP in their building, so they have some freedom in that and some of the activities that they do with them. Our bullying prevention, same thing. They're really good about coordinating these efforts. A lot of our student assistant professionals get together like, hey, what are you planning for this week? Let's coordinate, especially the ones that are within the same area. They're like, hey, let's launch the same messaging at one time, which has been really effective for our region. And we have some more examples coming as well. Next slide, please. Our substance use prevention campaigns. and then our mental wellness. And they also do a mental health awareness month. And so the bingo, the self-care bingo has been a hit for our youth, and coming in and getting a prize. We really try to be mindful that if you have things like stress balls or pencils, everybody's going to run to your table and just want one. So we want to make sure that we're actually delivering a message and a task is associated to it, whether it be a pledge, whether it be, okay, well, list out what some of your self-care, tactics are. How do you get through the week, that kind of thing. So really making sure that we are delivering the message, and it's not just, hey, we're going to give you guys a bunch of balls to cause chaos at school and throw around. So next slide, please. And again, just some of the supplemental campaign ideas that some of them do. Okay, next slide. Okay, so this is one of our tier 1 and tier 2 type elements, because multidisciplinary team meetings are important for both of the tiers. So we do expect our SAPs to participate in these, because sometimes referrals come out of it, or maybe they had already been working with the youth, and these meetings bring all the support staff together where they have important information that is useful for the SAP that they may not be seeing in other classrooms or out in the hallways, things like that. So we do ask that they, one, participate because of the referral source, but also they're a resource. So if there's a group of youth that have been brought to the table with concerns, they can be somebody of support to say, hey, I know of this resource out in the community that may be appropriate for this individual, and really show like a solution focused and be part of the team and assisting. And that's really important for the SAP role. Relationships with kids, yes, we all know that very important, but the trust and the relationship with the adults who are also working with these youth that need assistance in various ways, that's important as well. So we do ask that they attend those at least monthly. Most buildings are pretty good about doing that every other week. And again, it's for referrals, it's for resources, it's to identify youth that could benefit from different services. So next slide, please. Okay, so we're going to go over our tier 2. So our SAPs, they spend the most time providing intervention, and that's the focus of it. And so we're going to go through all the different elements on that as well. Next slide, please. So our behavioral health screenings. So each youth that is referred to the SAP does take a GAIN screening. It's a short screener, and it identifies substance use concerns, mental health concerns, different community concerns. And this is how we kind of focus our intervention with the youth. It seemed like, okay, what is the score? Where is the need? Because sometimes we do get referrals that's like, okay, this is disciplinary. They're in trouble for X, Y, Z, but based off the relationship in the screening, we see that like, oh no, there's more concerns here that they could use assistance with. So we try to do that in the first to second contact. It just depends on the relationship and how guarded the youth is, because we really want to make sure that we're not requesting a lot of personal information when that rapport and trust is not there yet. But these have to be conducted with each youth that we serve. Okay, next slide, please. So we provide 2 different interventions, group and individual, and this is dependent on the youth and their needs. And so they each receive the same teachings, regardless of it being individual or group. The same group materials are used for individual and group. And we do that based off of the screening. And now interventions can change. So just because a youth may have been referred due to a substance use violation does not mean that they do not go into a group for mental health concerns or for coping skills and various things. So it is time limited. So we do expect that interventions happen once a week. And at least 6 sessions for it to be a complete intervention. It's not just we're meeting with youth to meet with youth. We're there for a purpose, and we're focusing on reduction or increase of something. Next slide, please. So the materials that we use is Trails Coping with COVID. But I'm sorry, not coping with COVID, Trails Coping Skills. And then we have different curriculum that we can use for substance use. We use Project Success, just various things that focus on just substance use education. It can be for interventions. We have our COSAP groups, which are really important. We want to focus on youth that are in households where their family may be using, or maybe they are around substance use, but they're not quite there yet. So we have those different interventions as well, and recovery support. We do have other availability of different curriculum as it comes out, as promising practice or evidence-based. And these individuals, these students that receive these interventions, we call them full students. Because sometimes you're going to get youth that just drop in, and we're not going to tell them, no, hey, you're not in an intervention, so you got to leave. We still have meaningful conversations with them and assess whether or not it's something that needs to be programmed in, or if it's a drop in and they had, a rough day. So next slide. Oh, pre and post test. Yes. An important part of this is evaluation. Is our services working? So every youth that is in an intervention, they are pre-tested, and then they are given the same test after the intervention is complete. And it's self-report, and they identify whether or not there was substance use reduction, if their mental health challenges got better, whether or not they felt that the program was even beneficial to them. So it does test them on various things. It is confidential. We don't identify the youth that put it in. It all gets aggregated into the data that we can see each building. So we do that as well. Next slide, please. Referrals out to external support. So we do focus a lot on educating and training our staff on available resources within our region or within their town, because there are times where we begin working with the youth and we give them a screener, we start going into the interventions, and then we realize, oh, wow, your substance use may be even more of a concern than it originally was. So it's really important that they know how to navigate outside resources. Where do you go if a youth is ready to have an assessment or substance use assessment? How do you help them through that? How do you talk with the parents? Are you also referring to the appropriate resources out in the area? And that's the most important. Like, do we know their insurance? Do we know if they're accepting? Because that's, as a parent, that would be one of the most frustrating things is, okay, we have these resources. My kid, he really needs help, or she really needs help. But then I get this resource that one isn't accepting my insurance, or they're not accepting new clients, or it's not what we needed. So we do train them quite a bit if a youth is higher acute in symptoms or has higher needs, or even basic needs. Do you know how to navigate that system with them? And you're showing them the appropriate resources for that. Next slide. I will be handing that over to Eric.
All right, well, I'm trying to start my video back up, but it says the host has, oh, there we go. And hello, Eric Bruns here again. So the Smart Center is the evaluator of, since 2021, since the very beginning, we've been the evaluation entity for the BH-SAP initiative. And it's been an incredible journey to be able to, or an incredible experience to be able to walk this path with AESD and the individual ESD representatives such as Adriana. I will say that the Behavioral Health Student Assistance Program in Washington State is very much on my mind today, because we're wrapping up a paper for a special issue on the youth behavioral health workforce and the crisis that we're currently experiencing in behavioral health with respect to our workforce. So as our hosts described at the beginning of the webinar, I mean, everyone knows we're in the middle of a real serious youth behavioral health crisis with symptoms of depression, anxiety. They've been on the rise since well before COVID for our young people. And what we hear so often, and at least until recently, the federal government was very supportive with specific pieces of funding and other supports to school behavioral health as a potential option for addressing the youth behavioral health crisis. So people are looking to schools to address the youth behavioral health crisis. But we have this behavioral health workforce crisis going on as well. And a primary way of addressing that crisis has been using paraprofessionals who can work within their scope of practice, an appropriate scope of practice, to take over certain kinds of activities that are appropriate to their level of training and supervision, which would then free up potentially clinicians to take on those referrals, such as what Adriana was just describing, for more intensive and targeted behavioral health services for kids who need it the most. So here we are at this incredible intersection with the student assistance program in schools, being able to provide something that is both one of the key proposed solutions to getting kids identified and helped earlier, so that their emerging symptoms of mental health problems or initial substance use problems do not become more severe by intervening earlier in schools, and using paraprofessionals, which can be a way to actually address the shortages in both behavioral health and school employed helpers for kids. So it's a real exciting opportunity to be able to take on this evaluation, because frankly, there isn't much research on a solution like this, despite the fact that it resides at that nexus of being able to potentially provide support to so many societal needs for addressing the behavioral health needs of our kids. So what we have done at the Smart Center here, and I have to recognize Casey Eady and Bethlehem Kabede on my team here at the Smart Center, who really are doing this work day in and day out. You heard Adriana saying that our students who are receiving support from the student assistance professionals, our practitioners, are asked to, and consistently actually do complete those pre and post intervention surveys. So we have data from these students and incredibly high rates of data completeness there, like way beyond anything you tend to see in a community evaluation kind of context outside of a formal research project. So we have the student pre-post data. We have activity logs that are also entered into a system called Looking Glass Analytics that help us know what the volume is of those prevention and intervention activities and services that Adriana was describing. We can also use those data to ask, how do the activities that the student assistance practitioners are doing, how much does that vary across the 9 ESDs? And what's really interesting is that it varies pretty substantially, which I think is evidence of the way in which this intervention, these services can be fit to local needs and contexts. So we have the services and outcomes data. We look at those. We also have fidelity and staffing data. So my team asked, how much are the student assistance programs across the 9 ESDs actually adhering to those indicators of fidelity? How much are they actually staying within this framework that we're trying to put out there for them, where they are supposed to be conducting the community outreach as well as the classroom prevention activities, classroom presentations, and early intervention with students in group and individual contexts. So we have the activity data, we map that to that rubric to say what's the level of fidelity, or the way, how much it's aligning with our intention for the program across the ESDs. And then finally, a third source of data is school and district partner feedback. So every year they're asked what their perspectives are on the importance, usefulness, impact of the behavioral health SAP as they experienced it in their buildings and in their districts, and what could be done to make it more effective. So that's what the data that we're focusing on are across those three categories. Go ahead to the next slide. So the first thing that we do, and we feed this back into the system, and we have these wonderful twice a month meetings with the behavioral health coordinators, with the program coordinators across the ESDs to kind of look at these data. But you can see just what kind of volume of prevention activities this program is promoting. So this is across, 50 odd practitioners out there, or 50 odd schools across the state. Over 4,000 SAP prevention activities conducted. The highest rate of these kinds of prevention services are awareness activities at the building and classroom level. But you can also see substantial amounts of formal curricula delivered. You also heard Adriana talking about the peer-to-peer work that the BH-SAP program tries to promote. Fairly substantial numbers of that kind of activity also going on. So, we can look at this by category of activity. We can look at it in terms of who is actually being interacted with. So on that final fifth column there, you can see 1,253 interactions with those staff in the buildings that the student assistance practitioners are working in those team meetings with respect to consultations or receiving referrals, trying to make sure that their role is aligned with their peers in the school's needs and their workflows and their school team meetings and so forth. So to answer the first question of our evaluation, we certainly see this extraordinary volume of services that of types that wouldn't be able to be accomplished by school staff as usual. You have to really invest in people with this kind of role if you really want prevention, formal school-wide curricula to get done, and it's happening as a result of the program. Next slide. So in addition to those prevention tier 1 activities, we also saw that at tier 2, nearly 3,000 students were directly served by the student assistance practitioners. Most of these students access the interventions through some kind of personal referral, and the vast majority were not disciplinary, although there were some that were referred to the BH-SAP, because of some sort of issue that led the student to act out or have some sort of intervention that they were referred to as a result of their behavior or their substance use. But the vast majority of the interactions between the SAPs and the students were not based on disciplinary referrals. And like I said at the beginning of this little spiel, what's really cool is that 82% of these, or one thing that's really cool from an evaluator's perspective, is 82% of these students actually had matched pre to post self-report surveys on their symptoms and their substance use and other behavioral issues before the intervention that they received in the group or individual format, and then after, which makes our jobs a whole lot easier, and it makes it possible to use these data from a research context, like I was saying at the beginning. So over nearly 3,000 students directly served at tier 2. Go ahead to the next slide. So then, what do we do with those pre to post self-report surveys? Well, we analyze the average and variation in the slopes of change across a number of domains. When it comes to improved mental and emotional wellness, again, despite the fact that these are paraprofessionals, they're implementing these group-based interventions that are relatively short-term. 43% of kids who came into this intervention with anxiety as a problem reported lower anxiety symptoms, like being able to control their worrying. 41% lower depression symptoms, 38% said that described a reduction from pre to post in feeling worthless or inferior, so increased self-worth. We don't have a comparison group here, But I will say that, I've done enough research to, be able to compare these on to the same or similar measures like the Children's Hope Scale or some of the symptom measures. And, to some extent, more intensive interventions delivered in schools by licensed professionals, you see similar effect sizes from pre to post. So there's real encouragement that there are real improvements, particularly in mental and emotional wellness, in students' self-reported coping skills that these interventions are conferring. Go to the next slide. You see an even bigger improvement in behavior problems. Again, it's self-report, but it's comparing the report of the degree to which they are doing things like fighting or being suspended after the intervention compared to what their report was before, and even bigger rates of reduction in physical fighting, suspensions, and like I was saying, 62% saying that they had gained some sort of healthy coping skills, like strategies to calm down when they're dysregulated. A real impressive figure that we're beginning now to look at more administrative data on to substantiate this is that 80% of the kids who got some sort of tier 2 service or intervention from the BH-SAPs who had some sort of attendance problem before the intervention reported being more likely to attend school after the intervention. And like I said, we're now getting both administrative data as well as healthy youth survey data at the level of the school buildings that these BH-SAPs are working in to see if we're actually seeing these outcomes reflected in the administrative and survey data. So again, more real encouraging results on impact of the services that the kids are getting at tier 2. Next slide. So the last thing I'm going to talk about, or actually second to last thing, is you heard Adriana and to some extent Aaron talking about how we're not just putting paraprofessionals into schools, even with supervision from licensed staff, without any kind of expectations on what their role will be or what their activities are expected to be. We are asking them, as Adriana was describing, to participate in at least 3 staff meetings per year at the school level, to provide at least 1 mental health and 1 substance use presentation in classrooms every year, to provide at least 4 days of mental health or substance use awareness activities every year. Definitely expect them to, when they have a student referred to them, conduct a more intensive screening using a standardized measure, I believe the GAIN-SS, to identify the students who might need more help. So there's a number of program components that we crosswalk their activity logs to this fidelity rubric. And what's really interesting is that Aaron and folks at the AESD have been saying since the beginning that the whole point here is to have something that is being done with consistency, that there's a structure, that there's supervision provided, and expectations that are role congruent for these paraprofessionals. And these are examples of some of those fidelity indicators. Well, that seems like a very good idea in general, but what's really interesting is now that we have a couple years worth of data, both on their activities and the kids' outcomes, if you go to the next slide, we've been seeing that the student assistance professionals that are achieving greater alignment with that fidelity rubric, actually the students that they're serving are reporting greater improvement in those symptoms and behaviors than the schools where the behavioral health student assistance professionals are reporting less consistent adherence to that fidelity rubric. So this is really interesting. We got to ask what the confounds might be here, but it suggests that indeed perhaps at the ESD level or at the student assistance practitioner level, the folks who are able to actually reflect that kind of systematic process of delivering student assistance, something about the quality of those folks' efforts is convening or conferring greater benefits to the students. It just reinforces Erin's point from the beginning, which is that we really want this to be something that is consistently supported, and that there is a very consistent structure around this program. Suggests that it's not just a good idea to make sure folks are staying in their lane and doing the things that we hope that they do, but also, you know, the folks who are able to do that more consistently might also be getting better outcomes. And then the last point to make here is that this is viewed as, just go to the next slide, as being incredibly important to the school partners. The building and district representatives that we asked that annual survey, I mean, we don't see these kinds of numbers typically out there. I mean, of course, when you ask people satisfaction, usually, you know, you often get 70, 80% satisfaction, 90%, but we literally have like over 140 school partners where maybe one or two said it wasn't very important or of the highest importance to have one of these people, a student assistance professional in their school. 97% saying that they see tangible evidence that it is resulting in better outcomes at a school level and at a student level. If you go to the last slide, you can just see some of the quotes from these partners. Those who gave some sort of qualitative feedback, 40 of them said that, gave examples of how SAPs are just such an important resource. Having extra supports for children impacted by substance use or other socioeconomic factors is a much needed resource. SAPs have been able to help specific students develop coping skills. So 20 out of the 119 mentioned something about their ability to promote better coping in students. 13 had some sort of comment that talked about how SAPs shift the culture of the school. That, for example, those small group sessions, the one-on-one student meetings, being on the student success teams, that this actually has school level benefits. And again, we now have healthy youth survey data coming to us from the Department of Health that will allow us to say, or to ask, whether the school buildings that have SAPs actually have a student population that are reporting better school climate compared to those that are matched schools that don't have SAPs. So we're really excited as an evaluation team to do that bit of analysis as well. So that's a summary of what we've found and what we're doing at a data level. And I'll kick it back to our hosts for Q&A or any other kinds of a discussion.
Thank you so much. We will invite Erin and Adriana back on too. I was just curious as you were speaking, thank you so much. This has been like so helpful to hear about. This is a great example of how we need to holistically take care of our youth and how the schools can play a major component in doing that. Looking at those on the call today, they represent clinicians, health plans, the healthcare authority, and many other more organizations that fit kind of in the healthcare ecosystem realm. I'm curious, how can we strengthen our relationship between this healthcare system and the school system to collaboratively and collectively support our youth? For example, I saw that you were talking about as one of the tiers was screening, and that you can complete screening. How do we communicate that with a clinician, or how do we communicate that to other groups who also support this youth?
So we follow the same process and procedure like a clinician would. We follow HIPAA, right? And so if we know that a youth is seeing a therapist, getting that ROI and kind of talking to them like, hey, what is it that you're seeing that they need to work on? How do we reinforce that? Or being part of that discharge planning that the youth has to go to inpatient or a psychiatric unit. How do we have that communication with them to ensure that they are being discharged with all their appointments, that kind of thing? And so really just opening up that communication, getting those ROIs, and being in touch with your own community. It's helpful when your SAPs know the resources that are available within their own towns and have those relationships, or they're part of those meetings that come in. If you have a WISE program that's coming in to meet with your youth, are you part of those meetings? Are you inviting them to any IEP meetings? Are you inviting the whole entire team? So we do talk a lot about that as well and train them on how to do that. And we do follow those same guidelines you would. And the screenings are for us, but I do know that that is, could be a common one for crisis or other clinicians as well, the screener that we use as well. And so that can be transferable in that way too.
Helpful. I think also as one of the tiers that you were highlighting, it was kind of talking about that parent community connection. And I'm curious where behavioral health is very stigmatized, both in general, but also within different cultures, different relationships. I'm curious, when you were trying to kind of educate the parent community group, how do you navigate both within your ESD, but also within the state? You can also think of it as rural and urban and different settings. How are you kind of navigating this topic that is really important, but also can hold a lot of opinions and stigma?
I think relationships, again, these, when we talk about going to staff meetings and that kind of thing, like our hope is that the staff belongs to that community, developing those relationships, because if you have a positive relationship with somebody, regardless of what your opinion may be, you still kind of listen to them. You still can have like a flow of communication, and offering different things in different languages that are more predominant in your area where that culture may not view, getting help for mental health concerns as being a norm or being looked at as negative. But if you're offering it as like, hey, it's not like we're not telling you that your student or you need to do XYZ. We're just, this is being offered to you if you want to come. And if you don't, that's okay. But that takes the relationship with the family. So being present for those things. Again, we do follow HIPAA. And if they're over a certain age, a youth can choose to receive services, but it's always encouraged to have, if they have parents in their life or guardian, and it is a positive relationship and in a sense, involve them still. So you have to create those safe spaces for anybody to be willing to participate in some of the stigma reduction type educational opportunities.
Thank you. You were also, I'm going to go, Dr. Bruns, you were sharing in the beginning or of your section about the really important piece of fidelity, but also some adaptations that are necessary to ensure that the program fits the culture, right? Fits where the group is at, fits the kind of the community needs. How, or like, what are some examples of adaptations to this model for local community needs, but how are you also navigating ensuring there's like the fidelity piece of that? It's a complicated piece to be in.
Well, I'm going to bring Aaron in to talk about that. As the evaluators, we are looking at the data, and what we can see is a couple of things. The first round of analyses we did where we mapped the activities to the fidelity rubric, it was lower. So that was in 22 to 23. And it's improved since that first kind of assessment and bit of feedback that we gave to the ESDs around how fully are you adhering to that rubric. But from a data perspective, so that's one point. From a data perspective, the other thing I'll say is that what we see is that you can meet the minimum criteria and hit fidelity, but still have great variation in the number, for example, of group sessions you do with kids versus prevention activities. And so it's from a data perspective, there's a minimum threshold for what we're hoping folks will do, and you can still have great variation compared to the ESD down the road or the school, another school, in terms of the proportion of time you spend across those different activities. So I don't know, maybe Aaron can weigh in on the practical questions of how do you balance local adaptation to the needs of the schools versus hitting that kind of basics of the rubric.
And Dr. Bruns is right on. And I think what we see is we have this fidelity rubric, and then what we do in our individual districts is we look at their health use survey data. We see what's happening, in real time there, what the school is needing, what the youth are asking for, and then a lot of times we'll add additional sessions, or we'll add some additional curriculum that may link in to supplement what they're doing for their social emotional learning. And so we've tried to really make it pliable so that it can be adapted to each individual community. And so far that's going well. We're hearing really good feedback from our schools, as you could see in some of the evaluation too, that really it is supplementing some of the things that maybe they're already trying to do, and putting that mental wellness and or substance abuse education components into it.
Thank you. I'm also curious, I think I may have missed this if it was talked about, was we keep hearing too in the spaces that we've interacted with in the Bree Collaborative, just how important it is for also an early intervention, meaning younger youth in elementary school. I'm curious if you have adapted your model to fit that yet, or what you're looking at kind of within that area.
We are using this model in elementary school level. So yes, and again, Adriana talked about relationships, right? It's so critical when we go into an elementary model. We're really working hard earlier to build those relationships with the school, with the families, for students, there. And so, but absolutely, we are serving elementary schools in this model. Adriana, do you have anything to add for that?
Yeah, it looks different again. So we adapt, we adjust to meet the population. The screening may not always be appropriate for that age group, and so we try to make sure that we're adapting appropriately. But we are serving. Our region does have one elementary school, so.
Thank you. There's a really, I know we're close in time, but there's a really good question in the chat that we wanted to pose was, are any of the services that you're providing billable? And if a district was interested, how would they get this program in their buildings, and how do they pay for it?
So currently, the services that we are doing with prevention and intervention, these are not necessarily billable through Medicaid or those kinds of things. We are partnering with healthcare authority and managed care organizations and having a lot of conversations as we continue to refine the model and show outcomes and show the evidence base behind it. And so we're excited about that. Some of the intervention work could be billed for licensed behavioral health agencies under intervention. So we are exploring that. And we also have districts. So we highlighted the 18 sites that we currently have that are funded through apportionment. But we have other sites that we are using this model that school districts are paying for, or other sources of support that we're using to do that. So if a school district is interested in this model, they can reach out to their behavioral health team at their individual ESD, or myself. I can get you in contact with those partners, and they'll make it work within your school district as well.
Thank you so much. And again, for those on the call, if you signed up for today's event, you will get a copy of the slide deck, and I believe the contact information for Erin is on that slide deck. So there will be information there, or you can look back at the recording and see our event. Well, we have reached the end of our webinar. We thank each of you for joining us today. If you could take a moment and complete the post survey, that is really helpful for us for feedback. We hope that you can join us for our next event, which is next Tuesday, where we're going to talk about how do you afford youth behavioral health. So the last question was really timely. There's so many questions of kind of how are we addressing this, and what are the opportunities and challenges. We're going to look more into alternative payment models and value-based care. So if you would like to join us, you're welcome to. We also have a handful of other events, such as a climate resilience on addressing the mental health toll of extreme heat and wildfire smoke, which will have a focus on youth within that event. We have a couple other events that I will send out to you and share if you'd like to join us. But I really just want to take a moment and thank our speakers for giving us their time, knowledge, and expertise, and sharing their great work with us. We are really appreciative of all the hard work you do and the opportunity to learn from it. So thank you all for joining us, and we look forward to seeing you at our next event.